Study says FluMist vaccine does indeed work, contradicting CDC. It came as a surprise this June when the Centers for Disease Control and Prevention recommended against using the nasal flu vaccine for the 2016 to 2017 flu season, citing a lack of evidence that it works. Now, findings from a Canadian study appear at first blush to contradict the research that led the Advisory Committee on Immunization Practices to recommend against that live attenuated vaccine. But things aren't so simple. In fact, the conflicting evidence about the live nasal flu vaccine offers an excellent case study on how complex the task of analyzing flu vaccine data and making recommendations really is. Sometimes the public wants a very simple message, and unfortunately life's not like that. Mark Loeb, the new study's lead author and director of the Division of Infectious Diseases at McMaster University in Ontario, tells Shots. Things change as the evidence grows and we understand more. Unfortunately, that's how science and clinical medicine work. The challenge is to be able to help the public understand the shades of gray here. Loeb's study focused on 52 Hutterite communities in rural Canada, because their relative isolation makes for an environment with fewer confounding factors. Researchers randomly assigned 1,186 children, ages 3 to 15, to receive either the live attenuated nasal flu vaccine or the inactivated flu vaccine by injection. During the 3 flu seasons from 2012 to 2015, 5.3% of the children in the live nasal vaccine group and 5.2% of the children in the inactivated vaccine group had lab-confirmed influenza, revealing that the two vaccines were equally effective. The study lacked a control group of children who did not get a vaccine, but previous studies showed a flu infection rate of about 10% among unvaccinated children and of 4 to 5% in vaccinated children in these communities, Loeb says. Rates of antibiotic prescriptions, ER visits, respiratory illnesses, hospital admissions and school or work absences were also similar across the two groups. These findings, published Monday in Annals of Internal Medicine, parallel the early evidence for the live nasal vaccine in the U.S. which led USP to preferentially recommend it for children for the 2014 to 2015 season. CDC data consistently showed the live nasal vaccine to be very effective in children until 2013, when the vaccine went from including 3 strains, trivalent, to including 4 strains, quadrivalent. And therein lies the rub. The new Canadian study used the trivalent vaccine, while USP analyzed data using the quadrivalent vaccine, and among U.S. children. Many of us felt very strongly that the live attenuated influenza vaccine was a better vaccine than the inactivated for children, and the data supported that, says Pedro Pedra, a professor of virology and microbiology at Baylor College of Medicine and one of the investigators involved in the nasal vaccine clinical trials in the late 1980s. But something happened when it became a quadrivalent vaccine. The CDC decision in June relied primarily on data from the U.S. Flu Vaccine Effectiveness Network, which assesses the health of people who have an acute respiratory illness with cough for at least a week during flu season and are at least 6 months old. Researchers compare the odds of vaccination among those testing positive or negative for flu to determine vaccine effectiveness. From November 2015 through April 2016, CDC data from more than 7,500 individuals, including nearly 2,300 children, showed the inactivated flu shot was 49% effective against any flu strain that season. But the live nasal flu vaccine showed almost no effectiveness at all that season or during the 2 previous ones. The inactivated flu shot outperformed the nasal vaccine for all flu strains in the CDC study, as well as in a smaller Department of Defense study. Experts disagree on how much, if at all, USP should consider this evidence when they meet again October 19 to 20. The flu working group communicates throughout the year between meetings, but recommendations are made only at the thrice-yearly meetings of the full committee. Would they even consider changing the 2016 to 2017 recommendations well after flu season has started? For one thing, comparing the trivalent and quadrivalent vaccines is like comparing oranges and tangerines, says Khosrar Talat, an assistant scientist at the Center for Immunization Research at Johns Hopkins Bloomberg School of Public Health. In fact, comparing any two flu vaccines involves a quagmire of issues, partly because every year, vaccines act a little differently, Talat tells Shots.